Good evening, everyone. How are you all? Welcome to First Aid AMC MCQ free 2-week session again. So we are almost at the end of the free 2-week session, right? So you only have today's class, and then our free 2-week session will be over with another question solve discussion, which will be on 23rd of March. And as you know that the course has already started, and a lot of you has already enrolled into the course. After 23rd March, which is, let's see what's the day. So 23rd March is Saturday. So our class will start from 26th. So 26th will be the next class. And the course will be ongoing from then. You are already doing our course class for this month. But again, for the course student, the actual classes will start from 26th. So I would advise anyone, you still have got one week in your hand. So in this 1 week, please make sure that if you want to join the course, you start the process and make sure you either send a message to me or you send an email to our email address and get the invoice, make the payment, get access to the portal, get added to our Facebook course group. So all of these things takes time. So I would definitely suggest all of you to make sure you do it, okay? If you haven't done it yet. Now, today is about cardiology question solve. And the last class you had with Dr. Rabia, and you had a class on just some random question solve. How that class go? Did you understand? Did you like the class? Yes, yeah. It's usually one of the best classes because Dr. Rabia is very well known for doing these question solve classes for years and years, and and a lot of students like her class. Okay, so I'm sure you have also done it. Now let's start our question solve class. So the recording of that class, it's not in the portal. Dr. Sana, are you a part of the course? I don't think we have uploaded that in YouTube yet, but it must be in your portal. Or if not, then I'll have to check with the team. First question for today. A 17-year-old male was running a race and suddenly collapses on the floor. Luckily, someone was there and performed CPR as patient did not have a palpable pulse and resuscitated him. Upon arrival to the ED, it is revealed that his father died at the age of 28. So there is a cardiac death in the family. He is now alert and asymptomatic. ECG was non-eventful and he is anxious to go home. What would you do next? So it's a 17-year-old, sudden collapse while running a race. There is a history of death in the family and very young age death. Patient is totally normal at the moment. You have done the ECG, everything is good. So will you just send the patient home, or do you think that you want to check few other things? And what's your diagnosis in this case? What do you want to rule out? Yes, so we want to rule out HOCM. Okay, so hypertrophic obstructive cardiomyopathy, that's our most important differential diagnosis in here. It could be also congenital, or it could be a prolonged QT syndrome. But in prolonged QT syndrome, you would get it in the ECG. So it's not prolonged QT syndrome, which also comes with sudden cardiac death in the family. So if you suspect HSCM in this patient, what you want to do? You want to send him home and arrange an outpatient consult. You want to just send him home, which you would not. You want to admit and refer this patient for a cardiologist consultation. You want to just send the patient home and do an outpatient echo, or you want to do a stress echo. Now remember, because you can, in the emergency department, you can't do a stress echo. So it has to be done by a cardiologist. So in these kind of cases, you will need to admit the patient to the cardiac unit, and cardiologist will decide what he wants to do about this. Is he happy for the patient to go home and get an outpatient echo, or because this patient has got this collapse history, what if he is doing some other things? Maybe he just went for a diving, or he went to climbing a mountain, and then suddenly he collapsed. Okay, so you can't send this patient home without further assessment. So that's why we are going to admit this patient, and then cardiologist will decide. What cardiologist will decide? So ECG normal, so cardiologist might want to do just a baseline echocardiogram. If baseline echo is abnormal, then they can do a stress echo. Okay, so for this case, admit and consult the cardiologist will be our first choice. Same kind of question. A young athlete presents with history of, okay, just 1 second. So against patient's will, did this patient say that he wants to go home? He said he is anxious to go home. So he doesn't want to go home, and we are not doing anything against the patient's will. A young athlete presents with a history of sudden syncope and dyspnea. ECG shows left ventricular hypertrophy. Patient's father had a sudden death at a very young age. What is your initial treatment? So same, this is a case of HSCM. In HSCM, you can get a left ventricular hypertrophy, right? So what will you do in this patient? What kind of heart failure this kind of patient develops? Diastolic heart failure, right? And for diastolic heart failure, we have a choice of either choosing a calcium channel blocker or a beta blocker. There is no beta blocker in the option, so we are going to choose the calcium channel blocker, which is verapamil in here. Okay, definitely no need of low molecular weight heparin, defibrillator, or adenosine. So see that if you understand the question, if you know the basic, then you can easily find out the option. Which one is preferred? Always beta blocker is preferred over calcium channel blocker. Initial means next. Okay, we discussed about HOCM and our treatment are beta blocker or calcium channel blocker. Moving on to next. A young girl, 15-year-old, collapsed at exercise. Her father had a HOCM. After ECG and echo, you find no abnormality. What will you do next? So the reason why I am giving this question back to back is for you to understand how much variation a question can have in the exam. Just from one topic, they can change the question in a lot of ways. A lot of candidates from other course, they they tend to memorize the question answer. We never ask you to do anything like that. It's not something, or it's not an exam where you can memorize just some question and answer it in the exam. Please make sure you do not do something like that. You should understand the theory in a very, very good way, and then you can definitely use those knowledge to come to a conclusion and to come to a right answer. Okay? Because in exam, the question will be changed. In exam, the question will be different. And I can't even think that why someone will memorize a question answer. It's very easy to understand most of the topic. It's very easy to do it. So please make sure you don't fall into those kind of trap, and don't listen to people who are saying you that just memorize some of the questions and you'll pass this exam. It's never been the case. So for something like this, so you have got a patient with likely HOCM, ECG and baseline echo is normal. What will you do? Halter, stress echo, repeat echo, or repeat echo after 3 years? We already know that we want to do a stress echo in this patient. Very good. Okay, now last question from HOCM. A 9-year-old male was playing football, and then suddenly collapsed on the floor. Upon arrival to the ED, it is revealed that his father died at 28. He is asymptomatic. What would you do next? Alter, stress echo, repeat echo, ECG echo. Still, some of you are choosing option E. See that's why I have to explain these questions, because you would never do an echo without doing an ECG, right? And even the questions that we have discussed so far, they have always done ECG first, and they have done then they do echo. So always remember, you will need to do a ECG first. Okay, and after ECG you do a baseline echo. If baseline echo is not doing anything, or you are not getting any finding, then you can go for a stress echocardiogram. Well, we said we can't do a stress echo, but there is an understanding about that question. So if we go back, that's important to understand that what we have got in the option. So option matters. Sometimes you might not have the best answer in the option, but you have to choose one option, right? And you can't say, or you can't write to the examiner that there is no good option in this case, in this question. So I'm not going to answer this question, or I'm going to write on my paper that this question needs to be changed. So you can't say something like that. You have to choose something from the option, and the best option, not just an option, the best option has to be chosen. So if you see this first question, if we have a cardiologist and if we are in the emergency department, then definitely I would ask the cardiologist to come and have a review first before I do a stress echo for a patient. So that's our best option in here. But do we have that cardiologist opinion in here, or nothing like that? So we don't have that option in this question. So when we don't have that option, we have to choose the next best option. Okay? Is it clear, Dr. Ahmad? A 16 years old male who presents with ejection murmur in second left intercostal space, which of the following is likely to be the diagnosis? Now this is a tricky question. You can see all the option has got atrial septal defect. So that means this patient definitely has ASD, but with ASD, what he has got, that's the question. Now let me discuss a bit about atrial septal defect, and then we can come back to this question. So ASD and VSD, these are the common congenital heart defect. We discussed this in pediatrics. So I'm not going to discuss VSD today, but ASD, So it is the second common congenital heart defect. And in this case, the actual septum, so if this is your heart, you have got ventricular septum and you have got atrial septum. So in case of atrial septal defect, there will be a defect in this septum, which will allow blood to move from left atrium to right atrium. So in this patient, you can get a ejection systolic murmur in the upper sternal border. So this ejection systolic murmur this child has got, that's probably because of ASD. But we already know that every option has got ASD. So we need to find out, along with ASD, what else he can get. Okay? Now, aortic stenosis is not very common in a 16-year-old male. And also, aortic stenosis murmur, where it is best heard, right or left? Which intercostal space? Remember I told you, it goes like this. So aortic stenosis murmur is best heard on the right second intercostal space. So you can rule this out. Mitral stenosis. Mitral stenosis is a mid-diastolic murmur. So it's a ejection systolic murmur, and also it is on the left fifth intercostal space. So mitral stenosis is not the possibility. How about aortic regurgitation? Aortic regurgitation is on the left fourth intercostal space, right? But it's also a diastolic murmur, early diastolic murmur. So that's also not our option. Even by exclusion, your answer comes to pulmonary hypertension. But you don't need to do that. You can easily know why it is pulmonary hypertension. Let me discuss. So patient who has atrial septal defect, they can have pulmonary hypertension as a complication of it. So in ASD, there is this kind of defect in the atrial septum. So blood always flows from high pressure area to the low pressure area. So left side of the heart has got high pressure. So from left atrium, blood will flow to the right atrium through this defect. And then more and more blood will move on to the right ventricle. And because right atrium already getting blood from all the extremities, now also from left atrium, so there is a lot of blood volume on the right side. And that's going to the right ventricle. And from right ventricle, there is also more and more blood going to the pulmonary artery. And that causes the pulmonary hypertension. Okay, it's just because of the septum defect, because of more and more blood coming from the left atrium, all the vena cavas, there is increased flow of blood to the pulmonary artery, causing this pulmonary hypertension. Okay, nothing to do with the murmur, but it's a complication of atrial septal defect. Okay, so that's our answer in this case. Making sense for everyone? It's not stenosis, Dr. Prakash, it's a pulmonary hypertension. Okay, hypertension means this patient has got increased blood flow. So we are not talking about, no, we are not giving pulmonary stenosis. What is hypertension, Dr. Prakash? What's hypertension? What's the definition of hypertension? Okay, so give me the, so hypertension means when there is excessive blood pressure or when there is excess pressure of blood on the arterial blood vessel, arterial wall, right? So if there is lots of blood flowing through one of the artery, definitely the blood pressure will be increased there. Yes, right? Increased blood volume can cause increased blood pressure. So that's how it is. Any specific type of murmur are important? Yes, we discussed that in our cardiology class, Dr. Munir. So the important ones are all the murmur related to aorta and mitral. So mitral stenosis, regurgitation, aortic stenosis, aortic regurgitation, these four are the important ones. Okay, moving on to the next topic. A young guy, while playing cricket, suddenly had a syncopal attack. Syncope means loss of consciousness without any convulsive feature. Soon he spontaneously recovered and started fielding, continue playing rest of the game. What was the cause? So syncope means sudden loss of consciousness. There is a lot of syncope, cardiac syncope, neurogenic syncope, there is reflex syncope, then there is vasovagal syncope. So lots of causes are there. But the important thing to know is that if syncopal attack happens suddenly and patient also get a spontaneous recovery, that's cardiac syncope. So when syncope happens suddenly and the recovery also happens suddenly, that's cardiac syncope. Neurogenic syncope, there is no specific rule about this sudden fall or sudden recovery, but vasovagal syncope has a good rule. Vasovagal syncope usually will have a prodromal feature, which means that before they have the syncope, they will know that they are going to fall. So they feel lightheaded, they feel a bit of dizzy, they also can get sweaty, pale. Okay, so this prodromal feature will not be there in cardiac syncope. So vasovagal syncope, usually patient might be running or maybe standing for a long time in a hot sunny weather, and suddenly they can feel dizzy and lightheaded, and then they would fall, and then gradually they will recover from it. So that's how vasovagal syncope will present. Okay, but something like this one is most likely cardiac syncope. And when you get a cardiac syncope in a young patient, definitely you will need to rule out HOCM. Okay. So you can see in here, this is definitely not epilepsy because they say that there was no convulsive feature. So it's not an epilepsy. And you can see vasovagal if no prodromal sign. No. So if there is prodromal sign, then we go more with vasovagal. If no prodromal sign and recover is immediately, we go to cardiogenic. Okay. And if the recovery takes a bit of time, like let's say minutes, then it can be neurogenic syncope. A 45-year-old male presents to the emergency department with left-sided chest pain radiating to the left arm and jaw. There is no ECG changes and troponin is negative 4 hours since the onset of chest pain. So understand the question. 45-year-old came to the ED, left-sided chest pain radiating to the left arm and jaw. So you would be concerned about a myocardial infarction just by the first line. But there is no ECG change and the troponin is also negative 4 hours after the chest pain. He has been on sildenafil for erectile dysfunction, metformin for type 2 diabetes, ramipril for hypertension. What would be the most appropriate next treatment? You want to give him nitrate, heparin, morphine, beta blocker, paracetamol. Again, for this patient, aspirin would be the best, but that is not in our option. We have to choose something which is in the option. Let's see what we want to do. So this patient who has got a most likely acute coronary syndrome, either it is an unstable angina or it is a non-ST elevated AMI. Okay. So either it is a non-ST elevated AMI or unstable angina. It is not a ST elevated AMI given the ECG is normal. But again, troponin can be negative even after 4 hours. It can take time to go up, sometimes even up to 6 hours. So we will keep the differential as either it is an unstable angina or it is a non-ST elevated AMI. So the treatment, obviously for acute coronary syndrome, aspirin is the best, as we discussed. I don't know what's your name. Your name is coming as Samsung A236A. So please change your name so that I know who you are and we can talk. So aspirin is the best because it prevents further clot formation and it has the benefit, or you can say it has the survival benefit in any kind of cardiac event like this. So aspirin is always the first line for this kind of pain. Now, that is not in the option. What else we can give? Beta blocker paracetamol is not our option because that's not something we give in our acute coronary syndrome immediately. We have nitrate, morphine, and heparin. Heparin is still not indicated because we don't know if this patient has got a MI or not. Without a non-ST elevated MI, heparin is not indicated yet. So we have option of either A or B, A or C. Why we can't choose nitrate? Because this patient is on Viagra or sildenafil. It's contraindicated to give nitrate who is taking sildenafil because it can cause a profound hypotension. So again, nitrate is not our option in this patient for that cause. So what will be our best option? Morphine. Okay, but if aspirin was in the option, definitely that is your option of choice. Remember that. Yes, we give heparin in non-ST elevated MI. Clear, everyone? These kind of questions come in your exam a lot. Okay, and if you don't understand the answer of these questions, that means that the first class that we have taken for cardiac chest pain, you did not understand that class or you haven't done that class because we took just a single class for chest pain. So I hope there was nothing that we haven't touched. So the most likely some of you, if you are confused, just because you might not do that class. If you do it, you would know the answer of this question. Okay, so why we can't still say it is a non-ST elevated MI? Why, guys? Why we can't say this is a myocardial infarction? And if patient is not on sildenafil, still nitrate is not the first option for pain management. Morphine is the first management. So morphine will come first. Yes, so it is not non-ST elevated MI yet because we haven't got troponin increased. So even though the troponin can be elevated in 6 hours, that is why we are going to do repeat troponin, repeat ECG, but still we can't say this patient has got non-ST elevated MI because trop is negative. Okay, so there is no need to start the patient with heparin yet. We don't need to give heparin to ST elevated MI because you are going to send the patient for a catheter lab. So heparin is not needed for that patient. And we normally don't give heparin because the patient needs to go to the surgery and it can increase the risk of bleeding. So no need of heparin in ST elevated MI. And Dr. Marriott, again, I would definitely suggest to make sure do that class that we have taken for a chest pain. Okay, the first cardiac class, if you haven't done it or any of you haven't done it, please do that because we discussed all of this. Okay. In unstable angina, there is no need of giving heparin. Still, even if the patient was not on sildenafil, we would choose morphine. Okay, morphine comes first. So first aspirin, and then we give morphine. Then we go for oxygen, and if still patient is in chest pain, then we give nitroglycerin. So morphine is the first pain relief. Next question, a 72-year-old male presented with severe chest pain radiating to the back. On cardiac exam, you notice a diastolic murmur. Chest X-ray shows widening of the mediastinum. ECG given, what is the most appropriate management? So they're asking the best or definitive management for this patient. So 72-year-old, severe chest pain radiating to the back. Severe chest pain radiating to the back in a middle-aged or elderly patient, you would always consider aortic dissection as one of your differential. On the top of that, you have got X-ray showing widening of the mediastinum. Okay, when you have got something like that, you know that this patient has got aortic dissection. But they have also given a ECG in the next page. So this is the ECG, how it looks like. So let's see what we have got here. In this patient, we can see this patient. So remember we talked about the isoelectric line. So this is the isoelectric line. Okay. And ST wave. So this is your P wave. Then there is QRS. Then ST and then T. So this wave is the ST wave. And it should be in this isoelectric line, as you can see here. Now, if the ST got depressed, that's ST depression. So this is definitely ST depression. Same V2 has ST depression. V3 has ST depression. V4, V5, V6, they have got a bit of ST elevation, not very significant. If we look at lead 1 is fine, but lead AVL has got ST depression. But definitely if you look at lead 2, 3 and AVF, you can see that this one has got a significant ST elevation. If you see lead 3, ST elevation, AVF, ST elevation. Lead 2, 3 AVF is inferior leads, and you get ST elevation in lead 2, 3 AVF in inferior MI. So this patient has got a ST elevated myocardial infarction. We will discuss ECG in detail in our ECG class, not today. But this, you must understand a bit about it. Now, this patient has got aortic dissection plus ST elevated MI. That's tricky, right? So you want to give altiplase? No, you can't. Because if a patient has got aortic dissection, it is contraindicated to give thrombolytics. Give aspirin and intravenous morphine. Again, it's an aortic dissection. We would avoid giving even aspirin in this patient because it can cause more bleeding. Option C, give morphine, beta blocker, and arrange for a transesophageal echocardiogram. That's a good option. D, refer the patient to the cardiac clinic. Consider urgent MRI of the definitely not. Now, the question is, are we choosing between C or D? Do we need to wait for the cardiologist to come before we give morphine beta blocker? No, you would never do that. So this can't wait. Giving morphine, giving beta blocker, where you already know that this patient most likely has got a dissection, given the pain, widening of the mediastinum, it's already showing all the dissection feature. So you don't need to wait for the cardiologist to come and give morphine to this patient. That's insane. So you will give morphine, you start the beta blocker, because most of the patient who has got aortic dissection, their blood pressure is very high. And the first line antihypertensive for aortic dissection patient is beta blocker. So you give beta blocker, and then you need to confirm the diagnosis that this patient has got a dissection, and the confirmation comes with echocardiogram. Best is transesophageal echocardiogram. Okay, so that's our best option in this particular case. So you will always have to give a logic or reason behind your choosing an answer. In a real life scenario, what would you do? Would you wait for a cardiologist to come for giving the morphine? No, you would never do that, because even in the emergency department, it takes time to involve a cardiologist and for them to come and see the patient. It doesn't happen immediately. And we don't definitely wait for them to come. We can definitely start the initial management, and cardiologist can go from there. Okay. So just think about real life, then it becomes easier in the exam. So this is the widening of mediastinum. You can see how wide is the mediastinum, and you can see the aortic dissection. So you can see that this is your left subclavian artery. Anything proximal to this, that's type A dissection. Anything distal to this artery, that's type B dissection. Very good. Moving on to the next question. You have got an elderly man with multiple falls during the day, especially in the morning after waking up. ECG shows left ventricular hypertrophy, multiple ventricular ectopics. Orthostatic hypotension was noted. How will you investigate further? So you have got a patient, elderly patient, having recurrent fall, especially when changing the position in the morning. When a patient has fall in the morning, think about orthostatic hypotension as your first cause, or postural hypotension as your first cause. What is postural hypotension? When the change position suddenly from sitting to standing, sudden drop of blood pressure can happen and it can make them fall. It's common in elderly patients. So just only one reading is not enough. You need multiple reading showing there is drop of blood pressure when patient change position. And how much drop? So if the sitting blood pressure was, let's say, 150 by 80, and when patient stand, blood pressure falls down to 130 by 80 or 150 by 70, any of these two will be defined as postural hypotension. So that's right, Dr. Shahab, Dr. Spinell. So if systolic blood pressure drops more than 20 or diastolic drop more than 10, when they change their position, that's postural hypotension. So not only one reading, it has to be multiple reading showing this kind of blood pressure drop. So what will you investigate for this patient? You want to repeat the measure of blood pressure in supine and prone position. You want to go for a Holter monitor, or just check the electrolyte level for this patient. What you would do? I can see most of you want to do A. You want to measure the blood pressure in supine and prone position. What this will give you? What is supine and prone position? It's a lying position, right? So it's not changing the position. So changing position means it has to be either from lying to sitting or from sitting to standing. These are the things. Sit and prone position and supine position are same, right? You're just lying. So checking the blood pressure with supine and prone doesn't give you anything. This is a trap. A lot of candidates will not understand it and they will just take this as the answer, as most of you did. So if there was an option of repeat blood pressure in sitting and standing position, definitely we would choose that as our first or next step, but that is not in the option. Now, because this patient has got a bit of ventricular ectopic, it could be something related to heart, like some kind of arrhythmia causing this fall. So to check that out, we can do a 24-hour Holter monitor to look for any other arrhythmia. Maybe patient goes to a heart block sometimes, we don't know, and baseline ECG is not able to catch it, so we monitor. Okay? So there is no specific diagnosis you can say in this patient. It is still likely to be orthostatic hypotension, but you need to know that the option is not here to confirm orthostatic hypotension. Okay? But if there was an option of repeating the blood pressure in sitting and standing position, that would be our next step. That is not in the question. So we are going to check the Holter for any other arrhythmia or heart block causing this fall. Simple. In exam, it is important to keep it as simple as possible for you. If you overthink in the exam, you are going to get it wrong. If you think about some option you have seen when you did a question solve and that's not in the option anymore, then if you keep on thinking about it, it's not going to give you the right answer. You need to think logically and you need to choose an option from the choices that has been given. Always remember that. A lot of candidates overthink in the exam. They keep on thinking and thinking, and they think about something which is not relevant for that particular case. And they waste a lot of time. That's the part of doing the question solve so that you know I'm not going in haphazard direction. When I am reading a question, I know what I'm looking for and I know what's my next step for this kind of patient. Okay? That's all I want you guys to think in such case. The step-by-step approach. We have got a patient who has got fall. It's an elderly patient. Fall can be due to like 50 causes. We don't know. But what we have got here, we have got patient might be having a postural hypotension because it's happening in the morning. So we are checking the blood pressure in both positions. We have found that. So we have got orthostatic hypotension. What else I want to know? I want to know what's the heart. So we have done an ECG. We have found something. So even if it is orthostatic hypotension and we confirm it, still we would go for a Holter monitor in this patient just to find out any cardiac cause behind this fall, right? So that's how you would do when you would get this patient in your chamber or in your hospital. So that's how you think, right? So all I want you guys to do is to think in this way, the step-by-step approach, and think it as a real case. That makes the difference. So there is a bit of thing in here. If there is a syncopal patient, sudden syncope can be cardiac, can be neurologic. But if there is sudden regaining consciousness, that's cardiac. Gradual regaining consciousness, that's neurologic. Okay? So for cardiac, if there is abnormal cardiac exam, like you have got a murmur, then it could be any of these, HOCM, AS, MS, so you arrange a echo. If cardiac exam is normal, so no murmur, then likely that it could be arrhythmia. So you do a ECG, you rule out heart attack, and you do a Holter or telemetry. That's the step-by-step approach. Okay, so if you think about a cardiac syncope or cardiac fall, then this is what you do. You do a ECG, you do echo if you think there might be some valvular problem. If you think it is arrhythmia, then you do a Holter. Okay, very straightforward. If you think this patient might have got cardiac syncope, then you think, is this patient having a heart attack? So you do a ECG troponin. If there is no, if this patient has got a valvular heart disease, so then you do a echocardiogram. Well, that's not the case also. Is this patient has got any arrhythmia? ECG showed a bit of ectopics, but what if there is something else? So let's do a Holter or a telemetry. Okay, so that's how you would do. Now, problem in evening time doesn't mean anything. Okay, Dr. Imran? And it can happen. Postural hypotension doesn't mean that it will always has to be in the morning. It can happen anytime. Anytime patient sitting for a long time and then suddenly stand, that can also give postural hypotension related fall. So doesn't necessarily it has to be always in the morning after waking up. Next patient. So a young patient has been getting multiple lightheadedness and dizziness. His clinical features are normal. Chest X-ray ECG normal. Holter monitor shows ventricular ectopics. What will you do next? So young patient got lightheadedness, dizziness, but everything else is normal. And Holter showing just a bit of ventricular ectopy. Would you reassure the patient, send the patient for a stress test? You do a dobutamine-induced echo, plain echo. Now, we haven't discussed palpitation chapter yet, so it's understandable if you make mistake. So premature ventricular complex or ectopic ventricular complex, very common. 20% people with normal heart can have ectopics, and 90% cases it is asymptomatic. Symptoms are usually noticed at rest in bed at night. Drugs which can cause this, obviously digoxin is very commonly causes this PVC. Look for evidence of ischemic heart disease, mitral valve prolapse in women, thyrotoxicosis, and left heart failure. If symptomatic but otherwise well, see this line, if symptomatic but otherwise well, with a normal chest X-ray and ECG, you reassure the patient. For young patient with ventricular ectopic, we don't need to give any medication. So if symptomatic, our patient is symptomatic because he has got lightheadedness and dizziness. Otherwise well, with a normal chest X-ray and the ECG. So we have done chest X-ray and ECG, which is normal. So what will you do next? You will reassure this patient. Okay, so that's according to John Murtagh. We don't need to do echocardiogram. We would only do an echo in this patient if we want to give any medication. So never commence drug therapy without performing an echocardiogram in this patient, because this will help to guide the choice of agent, like what kind of antiarrhythmic we want to give. And if it is really troubling the patient, then the option would be giving beta blocker, such as atenolol or metoprolol. That can be given, but it's not must. For young patient, definitely it is not what we do. But for middle-aged elderly patient who is getting lightheaded, then, and if it is troubling them, then we can give it. But for a young patient having a bit of ectopic beats, no, we don't need to give medication. Okay, we can always reassure them. Most of the time, if you reassure this patient, they will stop getting the lightheadedness. It's very rarely this kind of PVC will do anything to a patient. Okay, but again, in a real life scenario, if a patient having a lot of symptom, it's troubling a lot, then yeah, we can give the option of giving beta blocker. That's not a problem. But you would advise the patient it is not needed. But if still patient is asking for it or patients having multiple episodes like this patient, we can give it a try with a beta blocker. That's fine. This is the ventricular ectopic. So this PVC is ventricular ectopic, Dr. Prakash. Again, that's the thing, Dr. Faria. Don't complicate the questions in exam. Make it simple. This is a young patient, okay? And they haven't said anything about high load ventricular ectopy. Everything is normal, chest X-ray, ECG. We would not think about ablation in the exam. That is why a lot of candidates fail the exam, because a lot of you might be a cardiologist in your country, or maybe you are doing a MD. I don't know what you are doing something in cardiology. Doesn't matter. You have to think like a very junior doctor in exam. Okay, and keep it very simple. Only thing that we check, when we do a question, we will it will be very straightforward, and we only think about that particular patient. Okay, but if we are discussing the case, definitely, if it is a middle-aged or elderly patient getting fall because of PVC, definitely we can go for a beta blocker. But for a young patient, if it is not too bad, I would not go for a beta blocker. I can reassure the patient that yes, I know that it's a bit of you're feeling dizzy, but everything looks perfect. Okay, but if it is troubling you, yes, I can offer some beta blocker. But let's say this patient is 20-year. Can we give beta blocker to a 20-year-old for the rest of his life? That doesn't make sense. Okay, so we have to always consider the age of the patient. Something like a beta blocker, if we're starting from the age of 20, this patient will be taking it for a long, long time. So when we consider something like a cardiac related medication, we have to consider the age and really the necessity of the medication. Next, again, so Dr. Prakash, we are reassuring the patient for the ventricular ectopic. I don't know what ectopic is making you confused. So ventricular ectopic is PVC they are talking about. It's the same thing. Okay? And you have done already. You have done a chest X-ray, you have done a ECG, you have done what you need to do for this patient. And you can see this in the JAM. Our patient is symptomatic with PVC, otherwise well, with a normal chest X-ray, normal ECG, reassure the patient. That's the treatment. That's the management, nothing else. Please don't make it confused, okay? And keep it simple for you. Now, as I said, that if it is a middle-aged or elderly patient who is getting fall out of a PVC, then definitely we can give a try with a beta blocker. For a young patient, again, if it is like really troubling the patient, we can always consider it. There is nothing wrong with that. But we will always consider to reassure the patient first. And sometimes if you reassure the patient and let them know that there is nothing wrong with getting a ventricular ectopic and your everything come back normal, most of the patient will not be very worried about it. Okay. And this PVC is not going to make cardiac failure for this young patient. So you don't need to think about cardio protection for a 20-year-old. Okay. A scenario about multiple drug, including ramipril, amlodipine, hydrochlorothiazide, celecoxib. So this is how drug-drug interaction come in exam. So what happens is that they give you a scenario and they give a patient who has got multiple comorbidities and on a lot of medications. And then they say that which of the following combination of medication can give this? So they're asking about which of the following combination can cause muscle weakness without tenderness. So what is about muscle weakness without tenderness? So muscle weakness can be due to a lot of conditions. So how we know what we should look for? We look at the option. If you look at the option, you can see few medications. So hydrochlorothiazide commonly causes hyponatremia, hypokalemia. Ramipril is a ACE inhibitor. It causes hyperkalemia. Okay, so this causes hyperkalemia and this causes hypokalemia. So this will counteract each other. So no problem. Amyloride is a potassium sparing diuretic, so it will increase the potassium. Ramipril, ACE inhibitor, it will also increase the potassium. So we have got hyperkalemia. Celecoxib, NSAID sometimes can increase potassium, but hydrochlorothiazide will decrease potassium. So again, it will counteract each other. So what's remaining? Option of B. B is hyperkalemia. Both hypo and hyperkalemia can cause muscle weakness. Both. Not only hypokalemia, hyperkalemia and can also cause muscle weakness. Okay. So you'll just need to find out which combination is causing either a hypo or hyper. All right. Next. You have got a ECG of an adult presented with chest pain. Cardiac enzymes and first ECG normal. Blood pressure 120/70. After 8 hours of observation, his blood pressure now 89/50. So he is now in shock. And in the ECG, you have found supraventricular tachycardia with heart rate 150. What you want to do for this patient? So we have got a supraventricular tachycardia. Again, we would discuss these things in our ECG class. So supraventricular tachycardia is a very important, like a case in exam, and it is one of the commonest arrhythmia that comes in exam as well. In supraventricular tachycardia, there is two kind of management. One depends on if the patient is stable or unstable. If the patient is stable, then what is stable means? Stable means the blood pressure is above 90/60. Patient is well alert. There is no shortness of breath, nothing like that. So in a stable patient, our first choice for SVT would be vagal maneuver. So vagal nerve stimulation. The vagal nerve stimulation, you can do it with Valsalva maneuver. You can do carotid sinus massage. So at the neck, you can even ask the patient to immerse the face in a cold water. So any of these can cause vagal nerve stimulation and can lower down the heart rate. So that's our first option in a stable patient. If that is not possible or that's not working, the second option is IV adenosine. IV adenosine is usually our choice for SVT, which is not working with a vagal stimulation. If IV adenosine, the first dose fail, you can try multiple doses. Most of the time we try 2 or 3 dose. If IV adenosine is not in the option, the other option would be calcium channel blocker, like verapamil. Okay? Still not working, our last option would be cardioversion, which means giving shock. Okay? That's called synchronized cardioversion that we give in this patient. If it is unstable patient, we can't do any of the other, but it has to be directly DC cardioversion or synchronized cardioversion. Okay? So that's the SVT management. For our patient, it's a patient who is unstable, so we would definitely go for synchronized cardioversion. All right? And defibrillation is not a choice for SVT or atrial flutter or fibrillation. Defibrillation is an unsynchronized shock, whereas DC cardioversion is a synchronized shock. Okay? So synchronized shock is given in SVT, AF, or like atrial flutter or fibrillation, whereas unsynchronized shock or defibrillation. Sorry, everyone. So I think what you had is that I think we had a sudden drop of the net. You guys can hear me now, right? So I was saying that the defibrillation is mainly when we go for giving a shock in a patient in ventricular tachycardia without a pulse or a ventricular fibrillation patient. Okay? These two cases we go for unsynchronized shock. And what is the synchronized and unsynchronized? So when we give a shock, if we synchronize the shock with the R wave, that's called synchronized cardioversion. And in unsynchronized shock means that because in VF you can't see anything, it's just chaos in the ECG. So you have to just give the shock. Okay. So when you don't synchronize with R wave, that's defib, and when we synchronize with the R wave, that's synchronized cardioversion. All good. So let's take a 5-minute break, and after that we will discuss more questions. Thank you. All right, everyone, let's restart. Any questions so far? Are you guys understanding me? Great. Let's have a look to this question. You have got a patient, let's say it's a 45-year-old male, and he's on digoxin, bisoprolol, thiazide, long-term history of hypertension and congestive cardiac failure with AF, atrial fibrillation, stopped taking meds for 3 weeks while on vacations, now presents with edema up to his knees and a raised JVP of 4 centimeter, but with a clear chest sound. So it's not pulmonary edema yet. Blood pressure is bit up, pulse is irregular, definitely because of atrial fibrillation. What would you do as an initial management of this patient? So these kind of questions are quite tricky in the exam. All you need to think that when a patient with cardiac failure, they get pulmonary edema, that's the time you have to start them with furosemide. Okay? Now, we can definitely wait and see for this patient that if we can control the heart failure, most of the time this congestion in the lower leg, like the knee edema, it can get better. But if a patient has developed pulmonary edema, then definitely you have to start furosemide for that patient. But this patient, we can see that he hasn't developed pulmonary edema yet. All he has is that starting of a decongested cardiac failure or decompensated cardiac failure. Now, for this case, because he hasn't been taking any medication, definitely he will get a bit of fluid accumulation. So for such case, we don't need to start the patient with furosemide only, because if you only giving furosemide, what will happen to all other medication? Because these patients, most likely the heart failure is related to hypertension and AF. So if you are not treating those, then just by giving furosemide will not be enough. Okay, so that's the idea of this question. You have to start all the medication that this patient is taking. So recommence all medication. That's our step for such patient. But the same case, it also sometimes can come like patient has got bibasal crepitation. When there is bibasal crepitation, definitely your initial treatment is furosemide, because you will need to at least remove this excess fluid from his lung. And then you will start all other medication at the same time. Okay? Clear, everyone? Okay. Now, the other thing is that this patient, I know that about beta blocker, but this patient is not a full-blown unstable cardiac failure patient. Unstable cardiac failure patient will have pulmonary edema. For that patient, no, we can't start them with beta blocker at that time. But it is still a stable cardiac failure. We can still control it. When we can control it, and definitely for a atrial fibrillation patient, we will need to give beta blocker and digoxin. Okay, but this patient, if he was having pulmonary edema, then we couldn't give the beta blocker. So very straightforward. If a patient has got, this patient was already taking all the medication that he needs, but he stopped taking them, and he has got a starting of a decompensated heart failure. Still, it is not into the lungs yet. And definitely a heart failure patient, if he stops everything, he will start to get fluid accumulation. Okay? But the patient needs to go back to his usual medication And most of the time, that is all that he needs. So this patient has got no pulmonary edema, given there is clear chest sound. So for patient with CCF with no pulmonary edema, we will start with all the medication they are on, because it's still a stable cardiac failure. If the patient is an unstable cardiac failure, where patient will have pulmonary edema, your first medication should be furosemide. Okay, that's it. Now, this is a bit of unusual and incomplete question, but we will make the best out of it. So you have got a patient who comes to you with palpitation, okay? And you have done an ECG where you have got M spike, QRS complex in all late. So I don't know what's this M spike they're talking about. So M spike is most likely bundle branch block that we get in ECG. But what kind of bundle branch block? We have to look it on the ECG. Could be right or left bundle branch block. So apart from this bundle branch block, patient also has got irregular rhythm. Heart rate is also elevated. And patient has hypertension, blood pressure 150/90. Patient only takes a statin, no chest pain, and they are asking that what will be your next step of management for this patient. So what will you do for someone? But first of all, you don't need to even look at the ECG to know the diagnosis. This is atrial fibrillation, because irregular rhythm with tachycardia, that's AF. For a AF patient, our management again depends on few factors. So first of all, is it a stable AF or unstable AF? Unstable AF will go for cardioversion, just like SVT. In case of a stable atrial fibrillation, you can either try rate control, especially when heart rate is high. So this patient heart rate is high. So you will try to take any of the rate control medication. So either a beta blocker or a rate limiting calcium channel blocker. If rate was fine, or even with rate control medication, the heart rate is not coming good, you have to try some rhythm control medication. And we have got some anti-arrhythmic medication for such case. So we have got flecainide. So flecainide, we have got sotalol, and we have got amiodarone. So any of these anti-arrhythmic medication will be our choice for rhythm control in AF. So that's our main treatment in a stable patient. Even with rate and rhythm control is still patient in AF, then you can try a cardioversion. So for this patient, you will try with them, because it's a stable AF and heart rate is high. So try either a beta blocker or calcium channel blocker. So we have got both beta blocker and calcium channel blocker in the option. So which one will we choose? Beta blocker. Okay, beta blocker is the best. And yes, that's right, Dr. Nahid. If in the previous question there was dyspnea, then yes, we would go for furosemide. And all medication means the medications patient was taking previously, Dr. Ahmed. Okay, good. Moving on to next one, a middle-aged man with a known hypertension started feeling dizziness and feels his heart is racing. It occurred after running. There was also travel history few days ago. He is on blood pressure medication and well controlled. No diabetes, blood pressure is not bad, with no postural change. What is the most appropriate next investigation for a patient like this? So It's a bit tricky for many of you, but if you have got a patient who has suddenly started to get tachycardia, like racing of the heart, and then feeling dizzy, and there was a travel history. When there is a travel history like this, so if we have got a patient with a travel history positive, and then there is a sudden onset of palpitation, shortness of breath, chest pain, or dizziness, we would be very concerned about a deep vein thrombosis which has traveled to the lung and caused a pulmonary embolism. Because the long travel, most likely patient was not moving, maybe slept around the whole 12 hours and then formed a clot in the leg. And then the clot can dislodge and can block the pulmonary artery, causing the pulmonary embolism. So when we suspect pulmonary embolism in a patient, what will be our next step? Now, I am not going into discussion about pulmonary embolism today because it's a long discussion. There is a lot to discuss about it, which we will discuss in our respiratory class in the course. But for your understanding, yes, we do the Wales score in these patients to find out what investigation this patient needs. If Wales score is more than 4, then we go for CT pulmonary angiogram. Okay. Now for this patient, when you know, like I would definitely say that in a real scenario or in the real exam, they would fulfill the Wales score anyway. Always remember, if your first diagnosis after reading the stem is pulmonary embolism, that means you are more or less sure that this patient most likely has got PE, then you would go for CT pulmonary angiogram as your initial choice of investigation. If you're not sure, like patient doesn't have any risk factor, nothing that you are not sure, you're 50-50 that it could be something else also. In that case, you could go for a D-dimer. But again, we will discuss the Wales score and other scoring system for a proper idea about PE in our respiratory class. But just to give you a bit idea that if your diagnosis or your first diagnosis is PE in a patient, which in this case it is, because there is nothing else you can think of apart from it. For that patient, your initial, your best, every investigation is a CT pulmonary angiogram. Okay? Clear, everyone? Because CT pulmonary angiogram, why we don't bother about doing a lot of other investigation? The reason behind it is that it can be a life-threatening condition. If it's a big pulmonary embolism, patient can die within minutes. So we don't have a lot of time to do a whole lot of blood tests and then send the patient for imaging when patient might be dead. So for something which is critical and life-threatening like this, we will always choose the best option immediately. Okay? Next, you have got a 60-year-old male, 10-year history of hypertension, feeling dizzy and lightheaded from this morning when he was doing exercise. He is a smoker, drinks 2 to 3 glasses of wine, blood pressure is 138/80, sitting and lying is 120/70, not bad. Currently on medication, aspirin, symptom lasted for 2 hours. ECG given showing SVT, heart rate around 150. Cause of this presentation. What will you say? A 60-year-old with a known hypertension had a dizzy and lightheaded episode in the morning while exercising. Is a smoker, known hypertensive patient. ECG shows SVT. For something like that, will you just think of dehydration? Definitely not. If it was a young patient without any other significant risk factor, you could think of dehydration because yes, it can cause SVT and it can cause a bit of dizziness. But for a 60-year-old with a multiple risk factor, definitely our main diagnosis should be ischemic heart disease. Definitely. Okay? Because always remember, if you have got a patient who has exercise intolerance, feeling dizzy or lightheaded during exercise, that is most of the time related to either heart or lungs. Okay? So this patient has got hypertension, smoker. We would be very concerned about cardiac risk. Okay? So definitely we would be thinking of ischemic heart disease. This patient drink two to three glass of wine. Drinking 2 to 3 glass of wine is standard drink in Australia, and it doesn't cause cardiomyopathy. Okay, so alcoholic cardiomyopathy is not your answer for this case. Hypertension, can it cause it? It can, but the patient's blood pressure is well controlled, so it should not be the only cause. Okay, and in exam, it is important to always choose the most important option or most urgent option. For a 60-year-old exercise-induced dizziness, what is the most important thing that we want to rule out? Ischemic heart disease. Okay, so that's the main thing you would remember when you are seeing a 60-year-old. And one of the cause of supraventricular tachycardia in middle-aged and elderly patient is ischemic heart disease. Okay. You have got a ECG with bradycardia, prolonged QT. Patient came with chest pain for 15 minutes, which was relieved by rest. Troponin normal, pulse normal, regular, blood pressure normal. What to do next? So if we have got a patient, like let's say that to make it complete question, this patient is 55-year-old male who came to you with a onset of chest pain for 15 minutes, relieved by rest. You have done troponin normal, ECG showing some of the bradycardia and prolonged QT. Will you repeat troponin? You will do an echo, coronary angiogram, not at the moment yet. Repeat ECG. Always remember that if a patient has got chest pain, which is more than 10 minutes in duration, even if it is relieved by rest, you can't just send the patient home without doing multiple ECG and troponin. At least 4 to 6 hours, you will need to keep the patient and do repeated troponin and ECG to look for any changes. Which one is first, ECG or troponin? ECG first. Okay, so you will repeat the ECG and also then you will repeat the troponin, and you will be doing this at least for initial 4 to 6 hours. If still after 6 hours, ECG normal, no changes, troponin is still normal, then you can send the patient home and the patient can go back to the general practitioner and they can order for some stress test in an outpatient if needed. So at least we do it like every 1 hour. You can do a ECG, and troponin, like you do it when first present into the hospital, and then you can do it again after 4 hours. All good? Moving on. You have got a woman who is, let's say, 60-year-old on multiple drugs, and one of them is digoxin. She presented with central abdominal pain and tenderness. Her pulse was irregular, so likely AF. Apart from CT abdomen, what is the most appropriate next investigation you would order for this patient? It is very tricky for you, I understand. So, atrial fibrillation patient is known to cause embolism in the brain causing a stroke, and it can cause a lot of other ischemia. One of the complications of AF is superior mesenteric artery ischemia. So that is what we call as mesenteric infarction or acute mesenteric ischemia. In acute mesenteric ischemia, patient most of the time has an underlying AF, and they can come to you, and these are common in elderly patient above 60. Central abdominal pain related to eating, so postprandial, profuse vomiting, watery or bloody diarrhea. If you examine this patient, there will be tenderness, rigidity around the umbilicus. Because what happens is that it's same like a myocardial infarction, the superior mesenteric artery gets blocked with a clot. And the part of that superior mesenteric artery that was supplying the part of the bowel, that part of the bowel doesn't get any more blood supply. So it can die and it can become irreversibly damaged if you don't treat it immediately. So this is a surgical emergency. So for such patient, if you are sure that it is acute mesenteric ischemia, you would just take the patient to the emergency theater. But sometimes if you're not sure, you will go for a CT angiogram to confirm the diagnosis. Okay? Now they already said, along with the CT angiogram, what is the next investigation you can do? When there is lack of blood supply in a place, there will be lactic acid formation there. So for that reason, if you do a serum lactate in this patient, it will be elevated. That will give you a bit of idea that how much necrosis has happened, and or if there is necrosis is happening yet or not. Okay, so very good test to know about it. So that's what they're actually asking for in this case. Quite tricky, right? Next, a 23-year-old man comes for a follow-up. His bilateral arm blood pressure was between 140 to 160 divided by 100 to 110, which is a bit high, right? On several occasions. Occasional headaches, rest of physical exam, urine analysis is normal, heart rate is 75 with mild left ventricular hypertrophy. Beta blocker, thiazides, captopril was used, and BP is still above 150 by 100. What this blood pressure is called? Guys, you have tried beta blocker, thiazide, captopril, still blood pressure is high, resistant hypertension. Very good, Dr. Prachi. So when you have got a resistant hypertension, especially in a 23-year-old, that is an odd thing, right? It's not usual. So that will ring a bell, and then you would like to know why this is the case. For someone like a 23-year-old, you would check for any other secondary cause of hypertension. So you would check for Cushing syndrome, Conn's syndrome, all the endocrine related cause, so thyroid, everything. But very important cause of resistant hypertension in this young patient could be renal artery stenosis. Okay, so for that case, and even if you look at the option, you can see that do ophthalmoscopy, is it needed at the moment? Not the must to do at the moment, but definitely we will do it to rule out any retinopathy from hypertension, but it's not must. Triamterone, no need to start in this patient. Repeat the ECG will not give us anything. Echo, what we are looking for in the echo? Nothing much. We can find out about the heart function, but it's not much information from echo. But this one, we will be able to look for a secondary cause. So Doppler or duplex ultrasound of the renal artery will be our best option out of these three options. Okay. Now, renal artery stenosis is not very common in this young patient. If it is, then fibromuscular dysplasia can be a cause. But most of the time, renal artery stenosis is common in middle-aged patient who has some atherosclerotic problem. So above 50, having high blood pressure, and you are not able to treat them with 3 or more antihypertensive. That's the time you would think of renal artery stenosis. Okay? Good. Yes, we can use spironolactone in a resistant hypertension, but for someone with resistant hypertension, before you try spironolactone, especially for odd cases, definitely do investigation to find out if there is any secondary cause. That's the best thing, because many times you would find something. You have got an old man, let's say 60-year-old, taking digoxin, hydrochlorothiazide, presence with palpitation, ECG was given. What is the cause of his problem? Now, I don't want you guys to answer these questions, or it's fine if you don't know. So, remember in cardiology class, we discussed about digoxin toxicity and how digoxin toxicity can present. So, digoxin toxicity can give you any kind of arrhythmia. And it has some ECG finding also. So, they have given you the ECG to help a little bit. So, if you see the ECG, there is a typical finding that we see in digoxin toxicity patient. It's called this kind of ST depression. See the ST depression with a reverse tick appearance. When there is a ST depression with a reverse tick appearance, that's most of the time we find in a patient with digoxin toxicity. Okay, so that's what they're trying to find out. And hypokalemia, hyperkalemia, they have different kind of ECG finding we will discuss in our ECG class. Next question, a patient on many medication such as metoprolol, digoxin, furosemide, ECG was given, but patient complains nausea, vomiting, abdominal pain. Digoxin level was normal. What to do next? And this is the finding in the ECG. So if we look over here, let's see if we have found any abnormality. Now, you would not get it, but this patient has got a first-degree heart block. Okay? The PR interval is very increased. Normal PR interval, so this is P wave and this is R. So normal PR interval is up to 5 small square. But this patient has got at least 10. So this patient has got a first-degree heart block from digoxin. The digoxin can give any kind of arrhythmia, any kind of heart block. So this patient definitely is getting side effect from digoxin. Even though the digoxin level is normal, patient having digoxin toxicity symptom, nausea, vomiting. That's the main symptom. So what will you do in this patient? C is digoxin, C is metoprolol, temporary pacemaker. For first-degree heart block, we don't give pacemaker. Angiogram, what for? C is metoprolol, commence verapamil. Doesn't matter, you're giving more or less the same thing. So for such patient, we will stop digoxin because patient has got toxicity. Okay? So even though blood digoxin level can be normal sometimes, still the symptoms can have toxic feature. If symptoms of toxicity is there, then definitely you're not going to continue it. Okay? So what will happen if we stop metoprolol? Nothing, because this patient has got digoxin toxicity. So if you continue digoxin, the toxicity will continue. Metoprolol doesn't give nausea, vomiting, abdominal pain, right, Dr. Faria? Next question, an ECG of WPW syndrome, heart rate 280, systolic blood pressure 105. What is the management? So let's discuss WPW syndrome. The ECG is not here. We will discuss how the ECG looks like. WPW syndrome is a very interesting condition. Let's say, so this is your heart, and that's the SA node. So electrical impulse usually start from SA node, then it goes into the AV node, and then from the Purkinje fibers bundle of his, it goes to the all over the heart, right? This AV node is there to block a lot of arrhythmia that starts from the SA node. So there is a conduction delay in this AV node. So even if there is a lot of atrial tachycardia, ventricle does not get all of those arrhythmia. So it doesn't affect your heart that much because of AV node. But in WPW syndrome, there will be an accessory pathway, and that pathway can bypass this AV node. So any kind of tachycardia that occur on the atrium, it can directly go to the ventricle. That's why you can see heart rate is super high, 280. Okay, so there is WPW syndrome. In WPW syndrome, we would not give any medication which can cause more delay in the AV node or which can block the AV node, because there will be still some electrical impulse which will come to AV node. Not everything will go through the bypass, right? So if you give some medication which will block the AV node, that's not going to work. That's going to make it worse. So that's why in WPW syndrome, it is contraindicated to give beta blocker, calcium channel blocker, adenosine, digoxin. So most of the common medications are contraindicated. The only medication you can give is antiarrhythmic, such as amiodarone. Okay. Clear, everyone? So you can't give verapamil, adenosine, digoxin. None of these will work in this patient. If this patient is unstable, yes, you can go for DC cardioversion. Next, a 65-year-old patient presents with lightheadedness and palpitation. Examination was clinically normal. He is on perindopril, L-troxin, which is thyroxine, verapamil, and anti-diabetic medication. ECG shows first-degree heart block. What is the next appropriate treatment? When you get a patient with first-degree heart block, your main thing is to stop any medication which can reduce heart rate. That's the treatment. If the patient is having lots of dizziness, lightheadedness, you can give them atropine. But your main management for first-degree heart block is just to stop any medication which can make it worse. So what can reduce heart rate? Beta blocker, calcium channel blocker. So you can see increase L-troxin. So we don't need to increase the thyroxine, definitely. Stop verapamil. So that's a calcium channel blocker. So that seems to be the option to choose. Stop blood pressure medication. No. Add digoxin. Definitely we don't need to do that. So stop verapamil will be our option to choose. Okay. So anything which reduce the heart rate, we will stop that. And Why not DC cardioversion in WPW, Dr. Shabab? This is still not, so systolic blood pressure 105, it is not an unstable patient. So for a stable patient, we don't give DC cardioversion. A child with upper respiratory tract infection is being treated for infective endocarditis. You have done blood culture and you treated the patient with penicillin, but still there is murmur present. What will you do? So infective endocarditis, it's an infection of the heart valves and also the endocardium, the inner layer of the heart. So patient with infective endocarditis, they come to you with an unexplained fever, loss of appetite, loss of weight, and new murmur. And part of managing the infective endocarditis is making sure the murmur is gone. If it is still murmur positive, there might be still some infected vegetations on the endocardium or heart valve, which is giving this murmur, even though you have treated with penicillin. So the only way to confirm if it's still there is to do an echocardiogram. Okay, so you do an echocardiogram and find out if there is any more vegetation left. We don't need to give antibiotic just yet. We will have to first find out. Okay. A pregnant woman at 36 weeks of gestation presents with dyspnea and orthopnea. Chest X-ray shows bibasal effusion and cardiomegaly. There is also bibasal crepitation. What is the next appropriate investigation for this patient? So this is our last question for today. So let's get it right. You have got a pregnant woman, 36-week gestation, shortness of breath and orthopnea, cardiomegaly, bibasal crepes. So what's the diagnosis? CCF, heart failure, right? So for heart failure patient, what will be your next investigation? ECG, echo, D-dimer, CTPA. Definitely ECG. So they are asking the next. So we'll start with the ECG in this patient. Very good, guys. So most of you actually did right. A lot of questions you are answering correct. I'm very happy with the progress. I hope you enjoyed the session. Now, because this is my last class for this free 2-week session, I want to go through with the course again, and you are allowed to ask any questions. Okay, so I will allow you to unmute yourself if there is any queries that you have. But again, the course is starting now. It has already started, but the course students, you are going to get your first course class. That will be next Tuesday, 26th. The only class in between is on 23rd, which is on Saturday. You're going to get another question solve class with Dr. Rabia. Okay. So I hope that this was helpful to at least understand that what AMC MCQ looks like, how we are going to prepare you for this exam. We always have a lot of students, and there's a huge amount of students who pass exam from our course. Even this February, there is, so far I have got 15 or 20 students who has passed. Passing February exam is very hard, but we have already got a lot of students who has passed this February exam. So it's not hard to pass the exam if you are in the right guidance and if you do your part. Okay.
Also, May I ask you the questions?
Yeah, sure, Dr. Faria.
Yeah. So you said that category exam is hard. So are there specific ones during which AMC exam is conducted?
Sorry, you're breaking up, Dr. Faria.
I wanted to ask you, are there specific months during which AMC exam is conducted?
Okay, good question. So AMC exam is conducted like every month except December and January. So we say that every year when the February exam start, most of the time new questions, new topics pop up in the exam, and it might be a bit hard for few candidates. But candidates who are well prepared, for them, no month is hard. Okay, and it is always the luck that what kind of questions you get in your exam. But I have seen throughout the last few years, our students, they go for February exam and no problem at all. They pass without any issue. Okay, but there is a myth for AMC that February and June exam is hard. But for our students, I don't have any problem. You can go for exam at any time you want. Okay.
Sir, I also wanted to ask you, like I was thinking of preparing for the exam in like 3 to 4 months. I did not wait for like I did not want to wait for complete 5 months to complete the course. So if I want to do it faster, how can I utilize your videos and so that I can complete the course in a shorter time?
So that's also a question, good question. So we are uploading all the previous batch recordings. So the theory classes that we are taking, that we have taken also in the previous batch. So theory class, I like not that much of a change that happens in just a batch wise. So definitely, if you are in a hurry, any of you can go through our previous batch recordings and you can finish the course in your own time. So in the orientation class, I will go through a little bit more about the previous batch, what we have done and everything, so that you know how to finish it in the shortest time. So that can be a very effective thing. If you have a time to prepare, definitely if you have the access to our portal, then you can start preparing by yourself by going through those recorded classes. That's the fastest way to finish everything. But on orientation class, I will discuss about how to do that a little bit more.
So one more thing, like what are the subjects that you cover towards the end so that someone who wants to prepare it faster would would finish the subjects you cover towards the end in between so that we can continue with the rest of the class and the end subjects can be covered by us like initially.
Yeah, so we give you the 5 months class schedules, like what we are going to cover in 5 months that we normally give in your Facebook group. But that will be given after these 2 week sessions. So likely from next week when we start the course fully, then you will get a schedule of what we are supposed to discuss in these full 5 months. Then you can just go through those topics from the portal.
So could you please explain how we can use your portal? Like I'm not able to understand how can I
We don't
utilize
discuss it at
the
the
time.
moment, Dr. Faria. So we can't discuss it here because it's a free session, and we are going to discuss next week when we are going to have the orientation class. Okay, how to use the portal, and we have already given a video on your Facebook group of how to use the portal. So you can also watch the video in the meantime. Okay, thank you. So
So one
Saturday
last question,
class,
sir. So one last question, sir. How much
yes.
before the exam can we book the exam? Like how prior do we need to book the exam?
So normally it's better to to book for the exam at least 2 to 3 months before your exam. Okay, at least. And you also need to start having some Epic account, having the AMC candidate number. So those things are first thing to have before even you can apply for the exam. So if you haven't done that yet, then even before booking the exam, you need to do that. Then you can pick a date. Okay, so ideally we say that for anyone who wants to finish the 5 months course first, I would say at least after 5 months, take 1 or 2 months for revision of everything and then go for the exam. But for someone who can finish the course with recording and you finish it in 3 months, then in another 2 months, you just revise everything and go for the exam. At least take 5 to 6 months preparation. That's minimum. And for and then when you have finished everything in 3 months, then if you think, well, yes, I am getting all the mock exams, I am passing the mock exams, getting it right, then it is the time to book an exam. Okay, so then you book an exam, ideally 2 to 3 months before your exam. So at least keep 2 to 3 months between your book date. And Dr. Divya's Saturday class will be cardio MCQs. We just did cardio MCQ today, Dr. Divya. So no more cardio MCQs. It will be random MCQs. Yes, there is a huge amount of mock tests, Dr. Ira, to like a lot. You can't even finish all those mock tests. And the mock test, we update mock test, we add more and more mock test every month. So there is no short of mock test to practice in the portal. I think you can. You have to go to the AMC website to know what is the closing date for a particular month. So they always give you a closing date. So before the closing date, you can book your exam. And I didn't get it, Dr. Nahid. So what about September records separately on the portal? And how many hours you need to give for study? It totally depends. There is no specific answer to this question, Dr. Kane. It always depends on how you are. Like, are you a quick learner or a slow learner? Do you need to write everything to memorize? Can you just read once and you can remember everything? So it depends on that, how many hours you need to give. Okay, but at least is 6 hours. Okay.
So is it that the AMC Part 2 needs to be given in Australia only, or can we give it in our own country?
And so you can give AMC you can give it in India. I think Pakistan was supposed to have one, like some center. Then you can give it in China, Thailand, Singapore. That's usually the Asian countries who have AMC exam center, and also Australia.
So for AMC Part 2 also you all have a course now. How long does that take?
So AMC Part 2, again, it also needs 6 to 8 months of preparation, but now you can give online exam. So you don't need to come to Australia for AMC 2. No, getting exam date is not hard for AMC. You can get it. And Dr. Sidra, I'm not quite sure about it. I heard that Pakistan was supposed to get exam center for AMC, and I heard it last year. So I'm not quite sure that if Pakistan has got the center or not yet. No, you don't. That's for part 2, Dr. Prakash, that you need to book the exam like very fast. Part 1, you can book it when you want. Okay, now moving on, just to give you the last bit of discussion about the course, all of you, I'm sure you know about the course detail. So our course has already started from 9th of March, but we are doing a free 2-week session currently, and our admission is still open because we haven't done a lot yet. It's just few sessions. We just finished cardiology, that you can say. Still ECG is left, and we have done few of the question solve classes. So you can definitely admit and you can go on with the course. A lot of people, even at the middle of the course, they start the preparation with us because all the recordings are already there. So it's easy to catch up. Classes usually start from 8:30 p.m. to 10:30 p.m. Sydney time. And the recording of the trial classes, you should be able to get it in our YouTube. So if you write First Aid AMC, you should get all the MCQ trial classes there, or you can also get it in our Facebook group. So we go for all theory will be discussed, just like how we did cardiology. We have 5 yearly sample question discussion up to 2024, so it's ongoing. Software-based mock exams, QBank, you get recording of every classes. So even after course is finished, you will get a recording of our classes for another 5 more months. So it's a lot of long time to get the recording and finish your preparation. Course fee $499 Australian dollar. Classes are now 3 to 4 days a week, and 2 classes on theory, and then we have 1 or 2 classes on question solve. All classes will be live, but if you can't join the live session, then there is option of recording. Recording can take 48 hours to be uploaded in the portal, so please make sure that allow us that much time to upload any videos, because it takes a lot of time to upload such a big file. And as I said, that we cover everything that you need to prepare for this exam. Nothing else that we don't provide. Okay, if you can follow everything that we are doing, it's more than you need it. The portal has a lot of questions, lot of recorded videos, which most of the students can ever finish. Okay, so it's a lot, but you don't need to go through everything. You only need to finish at least 1 year of question solve classes and then finish the theory. That's the ideal preparation. But if you have time, if you want to prepare more, you can definitely go through all our question solve classes. Okay. Extra classes will be taken on ECG, CT scan, and all of these things. So that's pretty much everything about the course. I don't need to discuss a whole lot about the course. When you see our course success in our Facebook group, you know that the course is not just like we are saying it. And most of you actually come and doing the class because you have heard about our First Aid AMC. So if you get recommendation from someone, it means that the course is satisfactory. No one recommend a course if it is not satisfactory or if they don't like it. So I would definitely recommend that if you are a beginner, middle of your preparation, or even at the end of your preparation, or you have appeared exam but unfortunately you failed, the course has everything that you need in every step. Whether you are a beginner or you are just finishing your preparation, you can definitely get a lot of help. Okay. All right, guys. So
So,
it was
so,
very
so
good
last
to
question.
have these sessions with you. Sorry, Dr. Faria, let me finish. I will answer
Mhm.
your questions. So, I hope that you enjoyed our sessions, and I hope that you have learned how AMC usually works. And I hope that even if you don't join the session, still you can start your preparation, pass this exam as fast as you can, because part 1 is just a start of this journey. And a lot of people will try to demotivate you. A lot of people will say things that actually not true. But I have seen the process. I have done the process. Trust me, it is not that hard. If you are well guided, if you know what to read, it is not the hardest exam. Especially part 1, you can pass it. And with part 1 and English, you can actually go for a job application, and you can start working in Australia while you prepare for part 2. Okay, it's not must that you have to pass part 2 to go for the work or job application. So it is a very good step, and passing the part 1 should be your easiest approach in this whole journey, because part 2 is the hard one, and people struggle to pass that. But again, our clinical course is again also one of the best course, and a lot of our students passed just in first attempt. So there is nothing you need to be scared of. Just do one step, one at a time. It's not a competitive exam. Everyone has their own way. Everyone has their own hurdles, own obstacles. All you need to do is to be satisfied with you that you have done enough to prepare for this exam. Doesn't matter how much time you take. Okay, someone who doesn't have a baby or a family, they can finish the preparation in 5 months and pass the exam in 5 months. But some of you who has work, who has hospital job, who has family, children, for you 5 months is not enough, and just accept it. Okay, it's not a competition. As long as you're doing some hard work, you are preparing, take the time and then be confident and then go for the exam. Okay, so that's important to remember. Have a steady partner, at least in a group of 3 or 5, so that you can talk to them. It's not just learning from them or doing question solve with them. It's also sharing your thoughts, sharing your feelings with them, and you make friends out of them. Okay, so it takes time, so don't get out of patience. Okay, thank you everyone, and I hope that we will see you again once our course starts. Dr. Faria, you wanted to ask some questions?
So I wanted to ask you that if we if we book our exam for a particular date, can it be postponed? If yes, would it require extra fees or something?
You can. If you, before the closing date of that exam, if you withdraw yourself, in my knowledge, there is no problem with that. Okay, but they usually change these things a lot. So go to the AMC website, and they have written everything there, that how to withdraw and everything. I heard that they don't allow you to withdraw anymore from the exam. Okay, that was the thing, like that was one of the thing. So once you apply for it, without exceptional circumstances, they don't give you refund anymore. That's my knowledge. But again, just go to the website and then you can definitely find it out. Or I can also find it out from the website and let you know next time. There is
No,
no
thank you,
age
sir.
limit for
Thank you so much.
job application. Thank you, Dr. Faria. And how to pay for the course. Payment is, we send you invoice to your email address. So either you can send me an inbox. So if you go to our Facebook group, then find Dr. Arshan Ahmed, then just send me a messenger inbox that you want to join the course, or you can send us an email. The email address is also given in our Facebook group. Okay, and once you do that, an invoice will be sent, and we will send you some other information regarding the course. And then once you make the payment, we will then proceed with further information. Portal access, so notes, mock exams, and everything will be until you pass your exam. The video recordings for a total 10 months. Yes, Dr. Prakash. I think I answered that question a lot of time for you, Dr. Prakash, about joining the course. You can join next month if you want. Yes, so you pay by the invoice link that will be shared to your email. That's right. Now, there is no age limit for job application, but visa is a problem. So there is a restriction of not giving visa for especially this kind of job. So if you're looking for a PR, and if you are more than 45 years of age, then there might be a visa problem.
Hello, Dr. Asa.
Yes, Dr. Neri?
Hello. Yeah, I just want to ask you a question. I was joined with your course last course, but unfortunately I have a situation. That's why I decided to join this course. And I did
Yeah.
join AMC account from 2021. It's not have an expire or limit for that. Can I still do the exam?
Yeah. I think there is a limit. In my knowledge, it is there is a 2-yearly limit. So
Oh.
you might need, there is a limit. So did you appear for did you book an exam?
No, I didn't book it yet.
Okay. So
Yeah.
I have to be sure about it, Dr. Neri, before I answer this question, because they changed this new thing, this rule again, that there was a talking about like you can't appear if it is like maybe for 2 years, that was mainly for if someone booked an exam and then they withdraw themselves, and then in the next, I think in the next 1 to 2 years they haven't booked any exam, then that's a problem. That was the main thing. But I'm not quite sure that if you have a AMC candidate portal number, and that will be expired or not. Most likely not, okay, because it's not a problem, because a lot of students, they go for 2 years, 3 years preparation, and I have never seen any problem with that. Okay.
Okay. Yeah, that is good. I worry about that.
Yeah.
If they have expired or not, because our account is eligible to do the exam. And
Yes.
it
So
takes
as long as
from,
it's saying it is eligible, you are fine.
but that's why I continue to study the course with you again. But I worry about because it's from 2021. If I finish the course, I prepare, and then they said expire, what can I do?
No, if
That's
it is
why.
expired, you just need to renew it. Yeah.
Okay. That's fine then. Thank you so much.
No worries. Thank
Yes.
you, Dr. Nuri.
Okay. Yeah. Please guide me because I have long gap. So some medication I didn't know, so I forget it. So that's why.
No problem at all. You will get along. So this time, don't miss the classes. Just finish everything.
Yes,
Okay.
I promise.
All
Thank you
right,
so
Dr.
much.
Thank you.
Okay. Yep. Thanks so much.
Thank you. All right, guys. So thank you, everyone. So it was very good, and I hope that you can pass your exam. Have a great night.